The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, ladies and gentlemen, dear colleagues. I'm Massimo Antonelli, the President of the European Society of Intensive Care Medicine. I have the privilege to introduce this webinar that is dedicated to the Surviving Sepsis Campaign International Guidelines in their new version right now published jointly into intensive care medicine and in critical care medicine. The campaign has been launched at the beginning of the year 2000 and had the intent of reducing drastically the mortality over the years. It is my real privilege today to introduce Professor Andrew Rhodes, who is one of our former president and at the same time one of the leaders of the Surviving Sepsis Campaign. His task today will be to illustrate you the major issues of the campaign. Andy, it's your turn.
Massimo, thank you very much. And good afternoon, ladies and gentlemen. It's my privilege to talk about the Surviving Sepsis Campaign and in particular the process we've been through in the last 2 or 3 years developing the latest set of guidelines and to introduce some of the concepts in the guidelines to you and perhaps some of the differences or the challenges between this set of guidelines and the previous set. First of all, I've got no disclosures to make about relationships with industry whatsoever, although Massimo has already described I'm a past president of the European Society of Intensive Care Medicine, which is clearly one of the major or one of the 2 key sponsors and supporters of this process. It is fair to say that the guidelines are a huge piece of work and it's taken many, many people to produce them and to develop them into what they are now. So I'd just like to acknowledge the support and the help we've had from all of the guideline panelists. There's 57 of us that are actually authors on the paper. In particular, the 5 group heads who did a significant amount of the work, Massimo Antonelli, John Savransky, Charlie Sprung, Ricard Ferrer, and Anand Kumar. It's also a process that's developed over the last 10 to 12 years with an improvement of the methodology in every time we've done this piece of work. And we now work very closely with the GRADE group from Canada who provide the methodology support. And it is not to be underestimated just what a significant help and support that this group have done, because as we develop the guidelines, as we write the PICO questions and do the literature searches and the meta-analysis and then the evidence-based weighing and sieving, it's effectively the equivalent of doing about 300-400 meta-analysis simultaneously. And also thanks to the sponsoring societies and the previous leadership of the campaign in terms of Phil Dellinger and Mitchell Levy, who've contributed immensely, and Dave McBride, who's provided administrative support. We first did this exercise in 2004, so the first set of guidelines were published in 2004, and we've tried to update these guidelines in a 4-year cycle ever since 2008, 2012, and this version, which was released a few weeks ago now in 2016. This current revision started in 2014, and the evidence was really cut off towards the end of last year, towards the end of 2016. The campaign was criticised quite intensely a number of years ago for being too close to industry, and there were the perceptions of inappropriate industry support and inappropriate industry influence. So for the last 2 versions of this guidelines, the guidelines have been developed without any additional industry support. Indeed, the only financial support has been from either the European Society of Intensive Care Medicine, the Society of Critical Care Medicine, or through academic grants, or through the support of other sponsoring scientific societies. We've had quite a rigorous conflict of interest panel, which has viewed and reviewed and attempted to mitigate and to mediate for any of the panelists' conflicts of interests. Although if you look at the authorship of the paper, you'll realise that this is quite a complex task. But I think we've taken this further than any set of guidelines ever before, and we've managed it as well and as rigorously as we can. One of the major changes in sepsis over the last few years has been in terms of the definition, and this has caused us quite a few issues and problems. Last year, a task force from, again, the European Society and the Society of Critical Care Medicine redefined sepsis in terms of the Sepsis 3, which was published in JAMA. And clearly this has changed the way we look at the condition, or at least how we define the condition. And we had a lot of debate and discussion as to what we should do about this, because this new set of definitions have yet to be completely validated, but they are out there now in the literature as the default definition of this condition. So everything we refer to in the guidelines, we refer to in terms of the new definition, but you have to understand that this definition hasn't been completely validated, and the evidence base that underpin the guidelines are all based on the old definitions. So this does add in an additional layer of complexity. We didn't feel it was the role and the job of the Surviving Sepsis Campaign Guidelines Committee to challenge or even to question the definitions. The definitions task force put it out there, and it's being debated in the public arena through the peer review process. So we acknowledge what the new definition is and have used it, but by no means are we commenting that it's right or wrong. And we do acknowledge the fact that the evidence base is all based on the previous definition, so we have to be a little bit careful how we interpret any of the data streams with that regard. So sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection, and septic shock as a subset of sepsis patients with circulatory and cellular metabolic dysfunction associated with higher risk of mortality. Effectively, what that means in reality is that where previous iterations of the guidelines described something called severe sepsis, it is now known, or just in this set of guidelines, described as sepsis. Sepsis 3 clinical criteria were not used in studies that informed the previous recommendations, so that just has to be understood and acknowledged. So how does the process actually work? How do we develop a set of guidelines? And it is worth understanding this for a few seconds, because the methodology that's used does define the output. So the reasons we've got an evidence set of guidelines, and the reason that may be different from a different methodology, is because of the methodology that's used. We codify or describe the PICO questions, which describes the patients that are being looked at in the studies, the intervention, the control, and the outcomes. And these PICO questions therefore form the basis of the literature searches that we get our librarians to follow. So we have about 150 PICO questions in this set of guidelines, which are defining the key questions that our panel members decided that we wanted to be looking at. You could argue there should be a lot more PICO questions to really understand and to unpick a lot of this work, And in future sets of the guidelines, they will undoubtedly be changed and probably expanded on, but that adds another layer of complexity and a significant increased volume of work that will be needed in order to understand that. So the PICO questions are developed. We get the librarians to search the literature in a standardized methodology. We use a minimum of 2 major databases. We use professional librarians. And then we develop the data, generate the evidence profiles, and from there we assess the quality and the grade of the recommendations in order to decide how we articulate that in the paper. You also have to understand that an evidence-based methodology is evidence-based to a certain extent, and when we have the data, we then have to extrapolate that data into some sort of verbiage that we can describe in a paper. And that's where there's an awful lot of discussion with the panelists. There's an awful lot of discussion often in terms of the interpretation of the data, especially where some of the more guidelines, some of the recommendations are relatively contentious. We've used a voting mechanism in that amongst the panel, and we've accepted a level of consensus as 80% at a level where we would accept that actually we haven't got unanimity, but actually we're happy and willing to go with that evidence base in order to formulate and develop the recommendation. We look at the evidence in terms of a number of categories in order to understand the strength or perhaps the weakness of the evidence for any of these guideline recommendations. We're looking at the risk of bias to the studies. We're looking at inconsistency in the results, in directness, and for that I mean many of the studies may not be performed, particularly in sepsis patients, and we're having to extrapolate from perhaps general critical care patients to those with sepsis. We're looking for imprecision of the results, publication bias, and a number of other criteria in order for us to enable to say this is strong evidence or perhaps weak evidence. When we're looking at the quality of the evidence, there is, as you'll all be well aware in evidence-based methodology, a bias towards randomized controlled trials. Indeed, an even bigger bias towards large, multicentric, multinational randomized controlled trials that can be generalized internally and externally. The lower quality of evidence comes down through small single-center randomized controlled trials, observational studies, well-done observational studies, or even control studies, or even in some aspects just expert opinion. And when you look at the recommendations, you're going to see that they're recommended as either strong or weak recommendations, but the level of evidence is then described as strong or weak to go with it. We've brought in a new type of grading in this set of guidelines that's known as a best practice statement. There are a number of areas in the literature, there are a number of areas in our practice that just make common sense, but it's very difficult to do a randomized control study or even any study to demonstrate an outcome improvement. And a good example for this perhaps may be the fact that we all recommend that the patient should have blood cultures taken prior to the administration of intravenous antibiotics. This is not something that's going to be particularly easy to ever demonstrate in terms of a controlled intervention, but it's something that we believe is right, and it's something we believe should be strongly recommended. So best practice statement is a strong but ungraded statement, so a strong recommendation. What we're effectively saying is you should do it, but it isn't graded because there isn't an evidence base for it. In order to fulfill the criteria for a best practice statement, we've used a set of defined criteria. Is the statement clear? Is it actionable? Is the message necessary? Is the net benefit or perhaps harm unequivocal? Is the evidence difficult to collect and summarize? What I mean by that is, or could we do a study to actually assess or test this? Is the rationale explicit? And is the statement better if formally graded? So we will only do this where the evidence isn't there. We'll only do this when it makes sense. And we should be only offering best practice statements when it's an area that cannot be formally tested in an interventional or controlled fashion trial. It is worth also understanding implications of what we're saying in terms of the strength of a recommendation. We issue either strong recommendations or weak recommendations. In terms of wording in the document, a strong recommendation will be defined as we recommend, whereas a weak recommendation will be we suggest. For patients, a strong recommendation is this is something you should just get on and do. For clinicians, most individuals should receive the recommended course of action for a strong recommendation, and for policymakers it's something that we should be looking at implementing and perhaps considering in terms of using as a performance indicator. A weak recommendation where we're saying we suggest the majority of individuals would want perhaps this suggested course of action, but many might not. So this is something we'd suggest you need to keep in your forefront of your mind, you need to be considering, but then you need to be thinking carefully about whether you're going to implement this action, perhaps in terms of the individual characteristics of the patients. Different choices are likely to be appropriate for different patients, and therapy needs to be tailored to the individual patient's circumstances. And we suggest that weak recommendations are not implemented by policymakers and perhaps shouldn't be used in order to guide performance improvement techniques. So the document itself was published towards the end of last year or the beginning of this year. I've just put up the mastered or the authorship just to acknowledge the huge amount of work that this group have put in. We're trying to get representation from all corners of the world. We've got representation from North America, Europe, Asia, Australasia. We've also tried to make sure that we've got a balance between male and female and resource-rich and resource-poorer facilities. The first recommendation I'm going to go to is we recommend that hospitals and hospital systems have a performance improvement program for sepsis, including screening for the acutely ill high-risk patient. I think this is a best practice statement. It's difficult to demonstrate in a controlled fashion. It makes a lot of sense, and I think there is now an abundance of literature or evidence out there that demonstrates that using modern quality improvement techniques can improve performance. So having a screening program that looks at sepsis and associating that with the Performance Improvements Initiative will undoubtedly identify more patients and can then significantly improve the outcome through improving reliability, consistency and delivery of evidence-based methodologies for this patient group. I'd like to focus mostly on the initial resuscitation, and the reason for this is because this is one of the biggest areas of change in the guidelines since 2012 to 2016, partly because of the generation of the previous set of guidelines for this area and the abundance of new large multi-central trials that have come out since 2012. So first of all, let's just remind ourselves of the 2012 recommendation. So the 2012 recommendation for initial resuscitation was, we recommend, so it's a strong recommendation, the protocolized quantitative resuscitation of patients with sepsis-induced tissue hyperperfusion. We recommended that during the first 6 hours of resuscitation, the goals should include all of the following as part of the treatment protocol. There was a suggestion that fluids should be titrated to central venous pressure, vasopressors to a mean arterial pressure, urine output should be achieved at over 5 mils per kilogram per hour, and that in addition, a central venous oxygen saturation target should be set to achieve a level of over 70%. I will remind you all of where this came from. This came from the study by Emmanuel Rivers, published in the New England Journal of Medicine in 2001. This was a single-center study looking at patients with septic shock. It is still referenced, it is still talked about today because it was probably one of the first studies in terms of resuscitation from septic shock that demonstrated a significant improvement in mortality. For a number of reasons, it has become quite contentious in modern times, but I think a lot of the points that were raised in this study, a lot of the philosophies that were described and the practice are worth reminding ourselves because many of them perhaps remain valid today. You can see on the screen the protocol that's taken straight from the New England Journal of Medicine that was described in this study by Manny Rivers. It's quite a complex protocol, but I just want to highlight a few areas of this protocol for you. Patients present, they're given supplemental oxygen, there's early instrumentation of these patients with central venous and arterial catheterizations. In particular, in this study, they had very early insertion of a central venous catheter that was modified to be able to monitor and target central venous oxygen saturation through an oximetric technology. Patients were then perhaps sedated, paralyzed and intubated if necessary, but fluids were titrated to achieve a central venous pressure of above 8 millimeters of mercury. Mean arterial pressure was then maintained with vasoactive agents to achieve a target between 65 and 90 millimeters of mercury. And then after that, central venous oxygen saturation was targeted with the use of either red blood cells, transfusion, or positive inotropic agents, dobutamine, in order to achieve a central venous oxygen saturation target of above 70%. Now, this is the protocol that's effectively driven the guidelines for the last 12 years for the Surviving Sepsis campaign and driven the recommendations for the initial management of these patients. A lot of the targets perhaps are physiologically not as astute or even rigorous as we'd like, but it has been up to recently the only evidence-based study that we've had to guide our thinking and guide our treatment strategies. In the last few years, there's been a number of other investigators that have published quite high-quality studies in this area. The Process investigators from the United States, the Arise investigators from Australia and New Zealand, and the Promise investigators from the United Kingdom have all performed large, multicentric, multinational, randomized controlled trials assessing or repeating the protocol of Emmanuel Rivers to see whether it's valid in modern day time. You will see from this meta-analysis plot published in Intensive Care Medicine in 2015 that the treatment effect associated with the Rivers style no longer remains valid when we take the aggregate or all of the data together, demonstrating actually that the recent studies seem to suggest that the treatment effect is marginal at least, but probably is no longer existent. I think it is worth reflecting and remembering how practice has changed over the last 15 years. Emmanuel Rivers did his study at a time when perhaps intravenous fluids were not used quite as early on and as aggressively as they are now, and they weren't in the culture of giving early intravenous antibiotics. So the data I'm presenting on this slide is from the Process study from the United States. This is looking effectively at what happened in the control groups of this study. The control patients in this study were given intravenous antibiotics within an appropriate time frame in 97% of occasions. They were given between 2 to 3 litres of fluid prior to randomization, and then another 2 to 3 litres of fluid in the subsequent few hours. And were given vasopressors, red blood cells, and dobutamine, perhaps in a very low level, but wherever necessary. The point I'm trying to make is the paradigm that these studies was performed in was in units that were able to deliver consistently and reliably early intravenous antibiotics and early intravenous fluids, and it may well be that the added incremental effect of a complicated resuscitative protocol is far less significant when we've actually got the basis of resuscitation up and going early on. And this is beginning to come through and drive how we're looking at the recommendations in the 2016 version. So what are the caveats or perhaps the limitations of these large 3 studies? Well, I think the overall management of sepsis has probably changed. In all these 3 studies, patients were given early antibiotics and quite a significant amount of intravenous fluid prior to randomization in the first few hours of presentation. Indeed, they were all given over 30 mL per kilogram on average of fluid. We need to be therefore very careful about over-interpreting the results in areas where this paradigm is not valid. These guidelines are set up not just for high intense areas, high quality institutions in North America or Western Europe. These guidelines are being set up to be delivered anywhere in the world where they have modern healthcare. Many parts of the world struggle to deliver some of these interventions in a reliable and consistent fashion. We've looked at this in many different studies, perhaps through the Solving Sepsis Campaign database of actually online practice, or even through the IMPRESS study, which we published 2 to 3 years ago. More often than not, these interventions in terms of antibiotics and intravenous fluids are only given reliably about 1 in 2 or 1 in 3 of the time. So many patients do not get these interventions delivered consistently outside of this research paradigm in reliable fashion. So although there seems to be little benefit from these interventional studies protocolizing therapy in this kind of quite sophisticated fashion, it is worth remembering that the treatment effect may still be there if we've protocolized the therapy in areas where we're not quite so good at delivering some of the basics care properly. So the Rivers work, I believe, was still very useful. And it's useful probably because it just described to us or provided us a construct on how to understand how to resuscitate these patients. And I'd put it to you that the construct remains just as valid today as it ever did then. Start early, treat quickly, have a degree of urgency about how you look at these patients. Give intravenous antibiotics quickly, correct hypovolemia, restore perfusion pressure, and in a few patients this won't be enough and you may have to tweak or titrate slightly more complicated therapies, and in those patients we'd advocate or we'd advise getting some more information as to what's wrong with the patient to direct the care appropriately. And these concepts are as important today as they ever were. So the challenge we had was how we described that, because it was very simple when we had only Manny Rivers work, because effectively we could recommend Manny Rivers' protocol. But now the protocol's been questioned, Now, the protocol does not seem to be as effective in modern day practice, but many of the philosophies or many of the underlying principles remain valid. So we thought we would state that up front, and we described this as a best practice statement. And we wanted to iterate or reiterate that sepsis and septic shock are medical emergencies. This isn't something that's really been described before. It's not often on the list of medical emergencies you are taught when you're at medical school, and I think that's where we need to be looking at it. So sepsis and septic shock are medical emergencies, and we recommend that treatment and resuscitation need to begin immediately. And this comes back to the underpinning of what I've learned or taken from Manny Rivers' work. Get on and treat them quickly. The majority of the patients with the basics will do well, and in a few patients you may need a little bit more. It's also worth remembering that just because the large interventional studies have not demonstrated outcome improvement, that does not follow on that identifying these patients early is not going to make a difference. So recognizing that this is an emergency, recognizing that early and urgent treatment is important, will coincide with the fact that we need to have a sepsis at the forefront of our understanding. We need to understand what this condition is. We need to recognize these patients quickly, and therefore any intervention that we've got, any process that we've got in our hospitals to identify the patients should enable us to recognize them early and treat them quickly. So how are we going to address, or how are we going to look at this problem? Well, the first thing to do is to diagnose the problem. The second thing is to get some sort of control of the source, and at the same time as we're doing that, we need to implement a resuscitative strategy. We believe that source control is important and urgent, although there is very little data that guides us in terms of how to manage source control, at least in terms of the timing in sepsis shock. A lot of the data that we looked at and found relates to how to manage a patient presenting with cholecystitis and when to intervene in terms of doing a cholecystectomy. And we've had to extrapolate that outside of that environment into what is a septic shock setting. So we haven't found good evidence for this, but we believe it's the right thing to do, and therefore describe this as a best practice statement. We recommend that a specific anatomic diagnosis of infection requiring emergent source control be identified or excluded as rapidly as possible in patients with sepsis or septic shock, and that any required source control intervention be implemented as soon as medically and logistically practical after the diagnosis is made. We would go further, and we did go further in the paper, and suggest this should be done within 12 hours. Now, it's important to understand why we said it should be done for 12 hours. In many patients, we would advocate you get on and do it urgently and immediately, but some source-controlled interventions can be quite difficult to arrange either logistically or practically for the patients. If a patient presents with fulminant peritonitis from a perforated abdominal viscus, we would suggest that you get on, resuscitate that patient and get the source control as soon as practically possible. If a patient comes in with an obstructed biliary system or perhaps an infected pancreas, getting an emergent ERCP or even an emergent laparotomy to drain a pancreatic collection can be difficult in the middle of the night in many parts of the world, and in that setting we would suggest that actually it can wait for 8 to 10 hours and can be received the following morning. So, initial recommendations for resuscitation. We've already described that in many of the interventional studies they were given 30 mL per kilogram of intravenous fluid prior to randomization. So the first recommendation we came up with was give some fluid and give it reasonably quickly. We recommend that in the resuscitation from sepsis-induced hypoperfusion, at least 30 mL per kilogram of intravenous crystalloid fluid should be given within the first 3 hours. We've put a strong recommendation for this, suggesting that we get on and do it, but recognise that the quality of evidence, especially when we're delineating 30 mL per kilogram, is relatively low. The rationale or the reasons behind this recommendation are that we believe it's important to get on and give some fluid to the majority, if not all of the patients, while getting more information, because nearly all of the patients will benefit from that fluid. The danger is, the default setting was that actually we should say that we should get some complex interventional measurements of physiology in place prior to giving the fluid, but that delayed the intervention and is not or was not practical in many healthcare settings around the world. So the debate of the discussion was not whether or not to give fluid independently or discretely to all patients. It really evolved around whether to give 20 mL per kilogram or 30 mL per kilogram of fluid to these patients. We opted and we went for the 30 mL per kilogram because that was the median level that was given in most of the randomized controlled studies that have been performed in the last few years. and seemed to be a level that, at least for the majority of patients, was unlikely to cause harm and would almost certainly lead to significant benefit. However, we do recognise that 30 mils per kilogram is a little bit of an arbitrary cutoff, and many patients may need significantly more. If we look at the process, the ARISE and the PROMISE studies, this was what they were given prior to randomisation, and then after that they needed another 2 to 3 litres at the minimum, often in many cases in the subsequent few hours. We're suggesting, or at least we're recommending, that following initial resuscitation, following this initial fluid therapy of the 30 mils per kilogram, further fluids should be given, guided by a frequent reassessment. So we're suggesting that actually probably the most important thing is that we get a clinician who understands what they're doing to the bedside. They can make an assessment of the hemodynamic status either clinically, or in some healthcare settings they're going to have some more invasive or perhaps more advanced hematological kind of monitoring. And we will give further fluids against some of those physiological parameters, probably through dynamic kind of measurements at the bedside in a logical and targeted fashion. What kind of fluid are we suggesting? Or we're actually recommending that crystalloids nowadays are the fluid of choice for initial resuscitation. There's quite a bit of data that suggests that intravenous starches are almost certainly harmful for the patients, but some of the other artificial compounds do not seem to be associated with benefit, are more expensive, and there is a suggestion that actually some of them at least may actually be harmful. So we recommend crystalloids as the fluid of choice for initial resuscitation and subsequent intravascular volume replacement in patients with sepsis and septic shock. If we're going to give a colloid, the colloid of choice seems to be now, looking at the evidence weighting, albumin, and we suggest that you may decide if you want to use a colloid that adding albumin to these patients, especially if you're using substantial amounts of crystalloids where you're going to be diluting the serum albumin levels, may be beneficial. But recognise that this is a weak recommendation for a low quality of evidence. So this isn't something we're strongly saying you just get on and do it. It's something you're going to have to think about at the bedside and make your own decisions on. Once you've given the fluids, probably the other target that you're going to want to consider is how to target blood pressure. There is some evidence that's come out. This is the ASFAR study that you can see in front of you in the last few years, suggesting that actually initial target of 65 millimeters of mercury seems to be appropriate. So we recommend an initial target mean arterial pressure of 65 millimeters of mercury in patients with septic shock requiring vasopressors. This is nuanced, and again you're going to have to make some individual decisions based on your patients. A patient with systemic or chronic hypertension may benefit from a higher level of arterial blood pressure. So this recommendation is based on those patients you don't know anything about. So it's a patient presenting through the emergency department. You have absolutely no knowledge of them. What do you set your initial target to? Once you set that initial target, you've set your vasopressors, you've got it to 65 millimeters of mercury. By that stage, you may find out more information about the patient, and that may be that the chronic status needs a higher blood pressure, in which case you can raise the target a little bit higher. Or you may find actually that the patient remains oliguric, remains underperfused, and you want to do a test or a trial of raising that blood pressure and see how the physiological improvement happens in front of your eyes. So we're setting an initial target and allowing clinicians then to individualize therapy depending on the individual patient requirements. So we describe giving fluid, we describe setting a blood pressure target by giving vasopressors. It's important then to understand what vasoactive agent we're going to use to get to that target. Our understanding of the evidence is that norepinephrine should be the first choice or the first line vasopressor, and that's what we strongly recommend. We recommend norepinephrine as the first choice vasopressor. In some patients we acknowledge we may want to add in a second vasopressive agent, either because the norepinephrine isn't working or because we want to minimize the levels of norepinephrine because we're concerned about it having an adverse effect. In these circumstances, the literature suggests or has looked at effectively two different agents, either vasopressin, arginine vasopressin, or epinephrine. And there's not much to choose between these two agents. They've been studied in slightly different concepts and constructs. We would suggest that probably vasopressin is the second line agent, but if you wanted to or needed to improve the perfusion as well as the pressure, in that circumstance epinephrine may be a better choice. So we suggest adding either vasopressin up to 0.03 micrograms per minute or epinephrine to the norepinephrine with the intent of raising mean arterial pressure to target, or adding vasopressin to decrease the norepinephrine dosage. It is important to recognise that using this kind of construct and using this kind of rationale and set of principles, not all of your patients are going to respond or resolve quickly. Some of them will remain in a shock-like state, and they're the patients that probably end up on our intensive care units needing more sophisticated interventions and measurement and more complex or more long-term therapies. I think there is a role here for actually understanding in more depth and more detail of these patients exactly what's going on. In this patients, we're recommending further hemodynamic assessment, for instance, such as assessing cardiac function, to determine the type of shock or the peculiarities of the shock for the individual patients if the clinical examination is not leading to a clear diagnosis. Effectively, what this is saying is that we're seeing a growing role and a growing need for echocardiography at the bedside in order to understand the shock-like state, in order therefore to delineate and guide our therapies when they have not responded to our initial interventions appropriately. In addition to echocardiography, in addition to ultrasound techniques in terms of understanding what's going on, there is a growing body of evidence that suggests some of the advanced hemodynamic variables can be helpful in understanding which patients should or should not be given fluid, at least, or in terms of which patients will or will not respond to a fluid challenge in terms of improving their cardiac output. Many of the static variables, for that could be central venous pressure, pulmonary artery occlusion pressure, are of limited physiological value in terms of diagnosing which patients will benefit or won't benefit from volume challenges, but many of the dynamic variables seem to be quite astute and quite strong in achieving this diagnostic kind of accuracy. So we're suggesting that dynamic over static variables be used wherever possible and wherever appropriate to predict fluid responsiveness. The dynamic variables may be just looking at the response in terms of cardiac output, response in terms of blood pressure, heart rate, in terms of a fluid challenge, or it could be looking at the pulse pressure variation, the systolic pressure variation, or sometimes the stroke volume variation, if you have that sort of technology available for you at the bedside. The original or the previous sets of guidelines have always recommended that in addition we target central venous oxygen saturation to assess how to give inotropes or further blood cells transfusion in order to improve our resuscitative capacity. We found, this is a meta-analysis plot taken straight from this set of guidelines, that actually there's a growing body of evidence that the evolution of lactate can help guide resuscitation, is probably as effective as measuring or targeting against central venous oxygen saturation, and is almost certainly easier to use. You can see here 1, 2, 3, 4, 5 studies that have effectively targeted or guided their resuscitation by trying to normalize or reduce lactate levels. Now, we're all familiar and we're all quite comfortable with the fact that lactate is not increased in sepsis simply due to tissue hyperperfusion. Lactate itself can be raised by increased aerobic metabolism. It can be raised by some of the agents or the drugs we use. It can be raised due to poor excretion of lactate by hepatic or even renal underperformance. But what is quite clear is that a reduction or a normalization of the lactate in response to resuscitation is a marker that the patient's improving. And a lot of the studies seem to suggest that actually if you use this as a marker to guide your resuscitation, it can be associated with outcome improvement. So we do suggest that guiding resuscitation to normalize lactate as a marker of tissue hyperperfusion can be beneficial in these patients, but it is a weak recommendation with a relatively low quality of evidence. In parallel with the resuscitation, at least the initial resuscitation of these patients, we're going to have to diagnose what the problem is and start performing some sort of definitive treatment. We recommend that appropriate routine microbiological cultures, and that's really talking about blood cultures in particular, be obtained prior to starting antimicrobial therapy in patients with suspected sepsis and septic shock, if doing so results in no substantial delay in the start of antimicrobials. We would suggest that you always take 2 sets of blood cultures, one for the aerobic and one for the anaerobic, and we get on and do it preferably within 45 minutes, which will enable the antibiotics to be given at least within the first hour of presentation. It is important that we don't delay the giving of antibiotics simply to take the blood cultures, but in most setups and most institutions, we should be able to deliver a set of blood cultures and a set of giving the patient appropriate intravenous antimicrobials within the first hour of presentation. So we recommend that administration of intravenous antibiotics be initiated as soon as possible after recognition, and in nearly all patients within the first hour for both sepsis and septic shock. And this is a strong recommendation, although the moderate quality of evidence. Previous iterations of the guidelines have delineated the difference between sepsis, or what was described as severe sepsis, and septic shock for the giving of antibiotics. This evidence, if anything, seems to have firmed up. It is slightly controversial because there's some conflicting meta-analysis in the literature, which meant that we had to repeat our own in order to get a better understanding of where we are. And the evidence does seem to be coming down in the majority of patients to the requirement for giving early antibiotics for life-threatening infections that are causing organ dysfunction or septic shock. What antibiotics should be given? Well, we recommend empiric broad-spectrum therapy with one or more antimicrobials to cover all likely pathogens. And it's important to understand some of the definitions of what we mean. A broad-spectrum antibiotic is an antibiotic that covers a broad spectrum, a wide number of different types of microorganisms. So a good example of this could be augmentin or tazobactam. We recommend empiric broad-spectrum therapy with one or more antimicrobials to cover all likely pathogens. That means that we need to understand what the problem is, so that we can understand what the likely spectrum of antimicrobial therapy that we're going to have to give is. And clearly that's going to be different from community or hospital-acquired settings, and it's also going to require knowledge of your local spectrum of bugs and agents that are going to be required, because clearly there's difference, especially even within countries and definitely between countries, in the spectrum of antimicrobial resistance, and therefore the spectrum of therapy that you're going to have to give. A new concept that's been described in recent years is that of combination therapy. So whereas broad spectrum antibiotics is one antibiotic covering a broad spectrum, perhaps gram-positive or gram-negative bugs, combination therapy is slightly different. Combination therapy is where we're giving two different antibiotics to cover the same antimicrobial, same microbial kind of bug. So it may be we're giving two specific agents to hit gram-positives and two specific agents to give gram-negatives. And the idea of giving two agents is then to facilitate the bactericidal effect, but also to facilitate the clearance of some of these bacterial pathogens in the management of this problem. There is not a strong body of evidence to support empiric combination therapy. It has significant implications which we have to think through, but it is out there in the literature. It has implications because as we're starting to recommend more and more antibiotics earlier on to these patients, that is going against the face of the need for antimicrobial stewardship programs and the development of antimicrobial resistance. So we suggest empiric combination therapies. This is where we don't know what we're dealing with. The patient's just come through the door. We're blind to the bugs that the patient's got. We're only guessing. So we suggest empiric combination therapy using at least two antibiotics of different antimicrobial classes aimed at the most likely pathogens for the initial management of septic shock. However, we must understand that if we're giving antibiotics early, we're not always going to be giving it to the right patients, and that as important as giving the antibiotics early is stopping the antibiotics if they're no longer needed. And this is where this conflict or this paradigm shift between the antimicrobial stewardship programs and the delivery of early antibiotics is coming into play. So we suggest that combination therapy not be routinely used for ongoing treatment of most other serious infections, including bacteremia and sepsis, without shock. And clearly we're stopping the antibiotics if we identify that the patient never had an infection in the first place. It's also worth understanding that actually the evidence for combination therapy is not so strong, if at all, when we don't have organ dysfunction. So if your patient's just got an infection, even if that's neutropenic bacteremia, we recommend not giving combination therapy because it may cause more harm than good in that setting. And clearly, it is important to keep the antibiotic stewardship at the forefront of your mind. So we recommend that empiric antimicrobial therapy be narrowed once pathogen is identified. So if at day 2, if at day 3, you know you've got pneumococcus, we suggest that you stop your broad spectrum activity and narrow the antibiotics down at that stage to deliver only what's needed, what's best delivered to kill the bugs that you've got. We suggest that actually we're limiting the course of antibiotics, at least in the majority of cases, to 7 to 10 days. There are some infections, perhaps bacterial endocarditis or complex abscesses which are difficult to clear, where longer courses of antibiotics are appropriate. but actually in the majority of cases, 7 to 10 days is more than adequate, and there is an emerging body of evidence that in some patients actually we can stop the antibiotics even earlier than that, but that body of evidence has not got to the point where we're happy or comfortable with recommending it in this set of guidelines for many patients. So at this stage we're saying a maximum duration of 7 to 10 days is adequate. For the majority of patients it's only a week recommendation, and you're going to have to take into account what the bug is, what site it is, and how the patient is responding to your therapy in terms of physiological or clinical clearance. Perhaps as important, if not more important, is that we're recommending daily assessment for the de-escalation of antimicrobial therapy in all these patients. So we're suggesting that actually in all of these patients, every single day, we're looking at them, we're seeing if the clinical systems have improved, we're seeing if actually they've responded to the therapy, and if the shock state is removed, if the patient is a lot better, it may be that we can stop the antibiotics considerably earlier. An area of controversy in the past has been the use of corticosteroids. Low-dose hydrocortisone has previously been recommended for the management of septic shock in order to reduce the dose of norepinephrine and to reduce the time to shock reversal. This recommendation has not been changed since the 2012 edition of the guidelines. We suggest against using intravenous hydrocortisone to treat septic shock in patients if adequate fluid resuscitation phasic therapy are able to restore stability. If this is not achievable, so if after giving appropriate fluids and giving the vasopressors you're not able to achieve hemodynamic stability, then we're suggesting as a weak recommendation intravenous hydrocortisone can be used. Now the reason we haven't changed this recommendation is because we're well aware that the adrenal study, which is being performed in mostly Australia and New Zealand, which will be a 5,000 patient study, is just completing, will be completing in the next month and a half, and will probably provide us definitive data, or at least better data, in order to guide this recommendation in future. So at this stage we've carried on with the recommendation from 2012, which is saying that in the majority of patients there is no need to give hydrocortisone or any corticosteroids to these patients unless the patients are not responding to all of the standard and normal interventions. We've then gone on to a series of recommendations that I'm going to cover in the next few minutes, looking at some of the organ supports. Mechanical ventilation. We're suggesting using higher PEEP over lower PEEP in adult patients with sepsis-induced or moderate to severe ARDS. And we're now talking about or recommending the use of the prone position over the supine position in patients with the most severe acute respiratory distress syndrome. There have been a number of studies published in the last few years which have come down to recommend to support this practice, and the growing body of evidence now is allowing us to make a strong recommendation for severe ARDS patients for the use of the prone position where your institution has the ability, the skills and the expertise to deliver that in a safe fashion. A number of studies have been performed in the last few years looking at high-frequency oscillatory ventilation in patients with severe ARDS. If anything, that seems to be suggesting that high-frequency oscillatory ventilation is associated with harm, so we're recommending against the use of this technique in adult patients with severe ARDS. And in addition, especially following the bulky studies being published looking at the use of routine beta-2 agonists being nebulized, inhaled or given intravenously for the treatment of patients for sepsis-induced ARDS, we note the level of harm that that's caused in the majority of patients, and again coming out with a strong recommendation against the use, or at least the routine use, of this therapy for this group of patients. One of the questions that always seems to come up when we discuss this is there's a growing body of evidence of how we treat patients with ARDS in terms of low tidal volumes and higher levels of PEEP, but actually not all of our patients fulfill the criteria for ARDS, and many of them are still on a ventilator, so what do we do about those patients? And there is now some evidence to suggest actually the same principles remain valid. The same principles of low tidal volume, recruiting the lungs of these patients and having a slightly higher level of PEEP remain valid even if they do not fulfill the requirements of ARDS, but the body of evidence is nothing like a strong, this is a weak recommendation or a suggestion, and we're going to allow clinicians to make their own mind up when assessing how the patient is responding at the bedside. Previous iterations of the guidelines, especially if we go back to 2004 and 2008, were strongly suggesting of tight glucose control. You'll all be aware of the controversial data for this topic, especially coming out of the ANZIX groups and the NICE study, which suggests that actually tight glucose control in unstable patients may be associated with harm. However, maintaining normoglycemia seems to be still valid and indeed very desirable. So the real question is not whether we should be achieving glucose control. We believe we should. The question is what targets we should be setting ourselves. And we're recommending a protocolized approach to blood glucose management in ICU patients with sepsis. We're suggesting or recommending that you commence your insulin when you have 2 consecutive blood glucose level over 180 milligrams per deciliter. And this should approach a target then of getting your blood glucose between 180 and 110, which you will notice significantly higher than the earlier tight glycemic control targets, which were setting targets below 100 milligrams per deciliter some years ago. So what we're trying to avoid is these patients becoming hyperglycemic, and we're trying to maintain them in a normoglycemic range with the use of insulin infusions wherever necessary. However, if you're going to use insulin, we believe that you should be monitoring your therapy quite closely, and we recommend that blood glucose values be monitored every 1 to 2 hours until the glucose values in the insulin infusions are stable, and then perhaps every 4 hours after that until or while they continue to receive the insulin infusion. The evidence base for this is relatively weak. In fact, there is little to no guided evidence telling us how often we should be, or how frequently we should be monitoring our patients. Therefore, we've issued a best practice statement for this area. In addition, we recommend that glucose levels obtained with point-of-care testing should be interpreted with extreme caution, as there is quite a body of evidence now that suggests, especially when we're looking at capillary measurements and for point-of-care testing, there can be significant variance and not very precise. In addition, we're suggesting the use of arterial blood rather than capillary blood for point-of-care testing, using glucose meters if patients have arterial catheters. Many of our patients require renal replacement therapy. Many of them have renal dysfunction and develop an acute kidney injury. And there has been a growing use of renal replacement therapy techniques quite early on in this disease process. We've looked at the recommendation, the indications for renal replacement, and have come up with this suggestion. We suggest against the use of renal replacement therapy in patients with sepsis and acute kidney injury for increases in creatinine or oliguria without other definitive indications for dialysis. So basically what we're saying here is we are not recommending, or we're not suggesting you use renal replacement therapy for a single measurement or just an isolated measurement of a creatinine that's up or a urea that's up. We're suggesting that you use it for the indications perhaps that would be standard to your practice. So the indications, in our view, for renal replacement therapy would be those patients who we need to maintain volume status because they're developing volume overload, they're severely acidemic, or they're hyperkalemic. But we would not institute it simply for a raise or an increase in creatinine or a mild oliguria. One of the challenges we have when we're looking at sepsis is these patients can be very sick. But in some patients, it is perhaps an end-of-life process rather than a disease intervention that we're going to target, treat, and change the overall trajectory of that patient's survival. So it is important that we think about the ethics and we think about the patients in a more holistic approach, and that we set goals of care for these patients so that we can be targeting our therapies appropriately in a sensible fashion. So we recommend that goals of care and prognosis be discussed with patients when we can and their families early on in the course of this disease process, recognizing that in some patients, sepsis may be a process that the patients are dying with rather than a discrete reason for dying. So some patients we're going to step back and we're suggesting that actually we need to take a concerted view as to what's appropriate and what's not appropriate, and that's going to be setting goals of care, talking about the prognosis, and then coming up with some sensible treatment strategies. We recommend that the goals of care be incorporated into treatment and end-of-life care planning, utilising palliative care principles wherever appropriate, in order to make sure that the quality of care that we delivered is of a high standard. And we suggest that the goals of care be addressed as early as feasible, but definitely no later than within 72 hours of intensive care admission. And we suggest in many scenarios, actually we should be thinking about this a lot sooner than that. So I've given you a bit of a run through of the guidelines, how we developed them, where we've come from. This is a number of the authors, not by no means all of them, This is at the Society of Critical Care Medicine office in Chicago. A huge thank you to everyone that participated. A huge thank you to all of you that have been listening. If you go through the document, it's quite a long document. There's effectively 93 recommendations. You'll note that only 32 of them are strong recommendations, which suggests or highlights how weak some of the evidence base is in some of these areas. This is something we're picking up with a new task force looking at areas that need further research, areas of weakness in our understanding that we can recommend to funding bodies to fund future studies for. There are 39 weak recommendations, 18 best practice statements. And in a number of areas we were unable to provide a recommendation one way or the other, simply because there was little to no evidence to guide it. So core principles, I believe sepsis and septic shock are medical emergencies. Therefore, I and we strongly suggest that resuscitation is started early, source control is achieved, intravenous fluids are given and antibiotics are given, preferably within the first hour. It is not the type of condition where we can prescribe a treatment and leave that patient to their own good. So frequent assessment and reassessment of the patient's volume status, physiological recovery, and shock-like state is crucial and very important throughout the resuscitation period. There's a growing body of data that suggests that we can use lactate as a marker to guide our therapy, but it is worth noting that venous oxygen saturation measurements have not proved to be harmful, and lactate is probably equivalent to it. So even though the new large interventional studies haven't shown benefit, they equally well haven't shown harm. Therefore, if you have a setup, if you have a protocol that's working in your institution that uses venous oxygen saturation, I'd suggest you just carry on using it rather than trying to change it too quickly, because that may deliver other problems in terms of delivery of complex strategies. So I think it's a complex condition. I'd like to once again thank all the authors and the supporting organisations for helping us develop this package of care, and I'd like to thank you all for listening to this webcast. Massimo, thank you.
Thank you very much. Thank you very much for your thoughtful and careful review of some of the principal recommendations. We do have already a number of questions coming from our participants, and I would like just to use the remaining 5 minutes to ask you some of these most relevant questions. A number of questions has been asked concerning the quality of food that should be given to our patients, and why 30 ml per kilogram body weight, when to use the albumin, when is the amount of fluid given enough to start the infusion of albumin, and which kind of fluid should be used, let's say saline or ringer lactate or whatever, which kind of crystalloids, just to start with.
Yeah. 30 mils per kilogram is an arbitrary number. For the majority of patients, it's going to be about 2 to 2.5 litres, so it seems about right. It's unlikely to cause harm in the vast majority of patients. It's the volume, it's the average volume that was given in all the recent interventional studies prior to randomization, so it seems to be what people are doing in their clinical practice anyway. It's also the volume that's been advocated in the previous edition of the guidelines, and that we've got quite a lot of observational data that seems to suggest it's associated with benefit. The reality is it is an arbitrary number, but it gives us some sort of guide as to what to do just to get on and do things while getting more information. What fluid? We're advocating crystalloid over colloids. Crystalloids come in a variety of forms. Our practice at our institution is to use Ringer's lactate. I think there is quite a bit of evidence that suggests that the avoidance of hyperchloremia is quite important. We did start looking at the evidence base for some of the more balanced-based solutions. The evidence isn't really there at the moment in order to really justify them in this setting, and had to be weighed by the fact that they're clearly significantly more expensive and even not available in many parts of the world. So we're recommending the use of crystalloids. We haven't come down in favour of balanced crystalloids, although I have to say that's beginning to be many of our practices. But perhaps the more important thing to think through is measure your patients, monitor your patients, and try and avoid hyperchloremia. That can be done in a variety of ways, but simply giving lots of normal saline will cause that problem, and that problem has been associated with harm. When to start giving albumin? to be honest with you, we very rarely would give albumin in our practice. There is some evidence that suggests that albumin can benefit the patients. The Albios study from Italy looked at this, but didn't really use it purely in the initial resuscitation. Looked at it more in the subsequent few days. There is some evidence that patients who are presenting with hypoalbuminemia may benefit from it. The body of evidence, especially when we're looking at some of the Australian studies, the sub-analysis plots seem to suggest there is some benefit. In reality, 30 ml per kilogram I'll give with crystalloid. After that, I'll start consider using a colloid in a small subset of patients who aren't responding to the intravenous crystalloids and have developed a tissue leak and peripheral edema, especially if I've got an albumin level that's very low. That may be a consideration, but I'd also weigh that it's quite an expensive agent in our practice, and therefore we would very rarely use it.
And someone else is asking if it's better to use fluid challenges instead of using right away the 30 ml per kilogram body weight, especially when we refer to certain categories of patients, for example, those who have the cardiac underlying disease, cardiac failure.
Yeah, we would nearly always advocate giving intravenous fluids against a fluid challenge to see what's actually happening. Often if the patients come through the emergency department, actually they're not necessarily in a state where you can easily challenge them and against targeted variables, at least in the initial phases. Clearly some patients are more complex than others, and that's why we have to individualise therapies at the bedside. This is giving some broad principles about how to manage these patients. On average, most patients will benefit from 2 litres of fluid rather than causing harm. Even in patients, if you're presenting with septic shock, even if you've got a degree of heart failure, you'll probably benefit from that 2 litres of fluid. There may be the very occasional patient that won't, but I think in the emergency department setting, that's a very, very rare scenario. We have to be a little bit more careful when we identify patients either in the intensive care unit or on an inpatient hospital ward, because perhaps in those patients we don't want to rush 2 litres of fluid or 30 ml per kilogram of fluid into them, because they've often already had more fluid than we think, and they're not starting from the same baseline. So we have to weigh up where we're seeing the patients and what they've had already, so that we don't cause harm. But the vast majority of these patients, 30 ml per kilogram is not going to cause a major issue.
Another couple of interesting questions concern the use of the butane, as well as the right time to use vasopressing, and why, at least into the operative manual, is suggested to use it into the algorithm before adrenaline.
Dobutamine, the suggestion for dobutamine is there is a small subset of patients who have quite significant myocardial dysfunction, who are not responding to shock, especially when you're giving vasopressors in terms of norepinephrine. I mean, those patients, they may benefit from dobutamine. That was a suggestion from Manny Rivers that's remained in the guidelines. It is something that we've debated quite strongly within the guidelines panel. Most of the experts would seem to suggest it's a sensible approach. It's a weak recommendation rather than a strong one. However, the data to support that strategy is not strong. The second-line vasopressin or epinephrine, there's no head-to-head studies that really allow us to make this definitive decision. There is more evidence for vasopressin. The safety evidence for vasopressin in terms of the study seems to be slightly stronger, so we'd probably recommend vasopressin as a second-line agent over epinephrine. However, in some subsets of patients, they may be underperfused, the cardiac output may be low, a pure vasoconstrictor may potentially be harmful in those patients, at which point perhaps you'd suggest that epinephrine may be a better choice. I'd suggest that actually go in with norepinephrine first, look at your patients, and you make a decision whether epinephrine or vasopressin is the second-line agent, depending on what you're seeing in front of you. The evidence to choose or discriminate between those two is marginal at best, so I wouldn't worry too much with which one you chose to, which you're more familiar with. And if they're really underperfused, I'd suggest epinephrine rather than vasopressin.
We don't have much time, but at least it's important just to address a different topic. There are some of the participants who were asking whether or not should be used any biomarker just to monitor the evolution of sepsis or make the diagnosis, or just decide if interrupt or not the antibiotic therapy. just specifically mentioning copeptin or procalcitonin?
Yes, so we looked quite a lot at some of the biomarkers. Procalcitonin is probably the one that's being studied most more recently. There's little data to suggest or to support the use of procalcitonin to initiate antibiotics, but there is some quite significant data that would suggest it can be used to monitor the progression of the or the resolution of the infection, and therefore could be used to stop the antibiotics in patients through the procalcitonin normalizing. Indeed, that's one of the suggestions that's in the paper I didn't bring out in the talk, is that actually you can use procalcitonin to guide the de-escalation of your antimicrobial therapy. We didn't get to look at some of the other newer kind of biomarkers that's coming through, but that's something we can pick up in future iterations of the guidelines.
Maybe we have time just for one additional question concerning again the early goal-directed therapy. Someone is asking if it should be totally disregarded or not considered anymore, and if the recommendations are substantially against the use of early goal-directed therapy.
I think the problem we have with early goal-directed therapy is what we meant by early goal-directed therapy. If you mean early therapy that's protocolized, I'd suggest that actually it's still a very powerful and good thing. If you mean should we religiously follow the protocol that was designed and described by Manny Rivers that we went through in the talk, no, I don't think that's necessary, and perhaps we can do better than that in modern day practice. So to me, early goal-directed therapy is still valid. It's just that the markers, the targets, and perhaps some of the agents we use are different than they were 15 years ago. So the concepts of starting resuscitation early, correcting volemic status, correcting perfusion pressure in a small amounts of patients, improving cardiac output remain valid. At the same time, diagnose the problem, get source control, and give early intravenous antibiotics of an appropriate nature after taking blood cultures. That will sort the majority of patients or improve the majority of patients, a vast majority of patients. And to me, that's what early goal-directed therapy is. If it's synonymous with the Rivers protocol, then perhaps no. But if it's synonymous with early targeted resuscitation in a sensible fashion, probably protocolized nowadays in order to get it done more consistent, reliably in our institutions, then absolutely yes.
There are so many questions that maybe we can just answer the very last one. There are some who are asking a comment concerning the use of the quick SOFA, if it should be incorporated into the diagnosis following the recommendations or not.
The quick SOFA is the latest version of the definition for sepsis. So at the moment, that's the definition. That's how we define the problem. To be honest with you, it's more of a research question in some ways than a clinical problem, because many of us will identify sepsis because we're just used to seeing it clinically. Quick SOFA can be used to objectively triage patients to identify them. But yes, that's what the definition is. Until someone proves it otherwise or discredits it, I'd suggest that that's what we follow. In new versions of the guidelines, I'm sure we're going to see more data that's using the Q-SOFA to identify the cohorts of the patients, to target interventions and guide our understanding. I suspect we'll see that come through in the next 4 years. It wasn't there for this iteration of the guidelines, partly because it was published during or halfway through the process.
Our time expired, and I want to sincerely thank you for all your time and all your thoughtful presentation in all different parts of the recommendation. And I want also to congratulate with all the participants who asked so many interesting questions. Thank you very much. Have a nice evening.
Thanks, Massimo. Thank you, everyone.